Yes, sir, we are live now. I'll just give an intro.
Okay, Parthiban.
Very good evening to all the medicine subscribers who have joined us today for this session. I apologize for the technical glitch that led to the delay. Now we have our most prestigious medicine faculty, Dr. Adhithya KNV, sir. He's a consultant physician in Panimlar Medical College. He did his MD medicine and is now the principal investigator at the Mayo Clinic USA. Today he'll be teaching us upper GI bleed. Sir, thank you for joining us. The session is all yours, sir.
Okay, thank you so much. I hope my camera is visible. Is it okay? Now is it
Yes, sir,
perfect?
it is fine. It is fine, sir. Yeah, it
Okay,
is perfect,
okay,
sir.
okay. Chalo, chalo. All the good things will take time. So don't worry. Sometimes delay happens. I'm nothing. It is okay. So let's. Today topic is actually my one of my favorite topic. Very very favorite topic. Upper GI bleed, because in GH whenever I was there, thousands of patients we treated, and it is very rewarding also. So whenever we speak about upper GI bleed, I get goosebumps. So this is one of my favorite topic. Thank you for giving me this topic to teach. Okay. So let's go for an introduction. See, upper GI bleed is very very important, because we see it is one of the abdominal emergencies which we see, and it is more common also. Upper GI bleed we see many times. Alcoholic people come in and just vomit in front of you. I should tell you one story in GH. When I was there as a MD first year student, I went with a good apron, white apron, and in the morning to the emergency casualty. What happened is, one alcoholic fellow, he came and he totally vomited on my coat. That's it. After that, I never wear apron. So like that, interesting stories are there. So please remember that any bleeding, which this is the important point. This point I wanted to mark. So if sorry that if I am unable to mark, 1 minute, I'll see the options if anything is there. Yeah, yeah. It's wonderful. So this thing, please remember, this is the thing which I want to tell. Please remember that any bleeding proximal to the ligament of 3G is important, because you have one thing, varicose, and you have non-varicose. So I'm worried about the varicose bleed. I'm totally worried about the varicose bleed. I'm not worried about the non-varicose bleed. And please remember, upper GA bleed is 4 times more common than the lower GA bleed, and as usual it is more prevalent in the males. So what are the common causes? Well, when you go to the Harrison, all these things, you see that the common causes are peptic ulcer disease, erosive gastritis, varicose bleed, and Mallory-Weiss syndrome, and Dilfoy's lesion. Where I am worried about this, I am mostly worried about the varicellar bleed. Varicellar bleed, please, I'll give you just a thing, small thing. Whenever I see varicellar bleed, first I will put IV fluids. First thing I do is I'll put the IV fluids. After doing the IV fluids, I give the two wide bore IV cannulas. Two wide bore IV cannulas I will use, and then I will use the pantoprazole. Pantoprazole, what I'll do 80 mg stat followed by the 8 mg per hour infusion over 24 hours. Then I use octreotide. Octreotide I give 50 micrograms stat followed by the 25 micrograms per hour infusion. So please remember, whenever you look for the upper GI bleed, all the things should be done in the fast. So in India, I have used all these studies because I'm more worried about the Indian population. In India, what all the things we can do, we should see. Then what are the common causes? Esophageal and gastric varices, peptic ulcer disease, erosive gastritis and esophagus, and Mallory-Weiss syndrome, and Dilfoy's lesion. Please remember Dilfoy's lesion whenever you have any upper GI bleed, and if you are unable to trace the cause, please think of the Dilfoy's lesion. And still I remember the case which I have seen, that is AV malformations and malignancy. Please don't forget about the AV malformation. We have very very classical cases like AV malformations, where you can detect that the patient in the intestine, and you can see, identify it, and you coagulate it, the patient will recover very nicely. And then esophageal and gastric varices, here you concentrate. Esophageal and gastric varices, it is very very important. First thing is portal hypertension, alcoholic liver disease, and chances of rebleed is very high. So these are the very very important things. See how beautiful it is there. This is the beautiful thing which you can identify. Whenever you see the varices is the esophageal, always look for the esophageal branch. Now coming to the this very important thing, that is portosystemic anastomosis. Portosystemic anastomosis, I want to tell you about the 6 areas. These are the very important. Please remember, whenever you look for the portos, these 6 areas you should remember. First is lower esophagus, another is upper anal canal, another is umbilical, another is the bare area of the liver, another is the patent ductus venosus, another is retroperitoneal. Please remember, this slide is very important for you. Whenever you are dealing with the lower esophagus, you should tell about the postal and systemic. Postal is the esophageal branches of the left gastric veins. Left gastric veins you should know, and systemic is the azygous veins. Here simple thing you can remember as lower esophageal branches of the gastric veins, and systemic is the azygous vein. When you're dealing with the upper anal canal, whenever you're dealing, portal is the superior rectal vein. Portal, please remember, superior rectal vein. Systemic is the middle rectal vein. Here you can remember as SRM, anal region SRM. Umbilical is the veins of the ligament of teres, and superior and inferior epigastric vein. And bare area of the liver is portal is hepatic portal veins, and systemic inferior phrenic veins. And patent ductus venosus, which is the rarely once they asked in the PGI Chandigarh, where you should remember is portal is the left branch of the portal vein, and systemic is the inferior vena cava. And retroperitoneal, portal is the clonic veins, and systemic is the body wall veins. Please remember, these slides are very important. Please, this slide, it is the black box. You should remember, before going to the exam, 50 pages you should see. In that 50 pages, this will come. So you should remember lower esophagus, upper anal canal, umbilical, bare area of liver, patent ductus venosus, and retroperitoneal. And peptic ulcer, this is, please remember, whenever you're dealing with peptic ulcer, this is always take history of NSAIDs and gastric and H. pylori and smoking history. Please remember here one important point. If head injury is there, it is comes under the Cushing's ulcer. If burns is there, it comes under the Curlin's ulcer. Okay. See, such a beautiful picture. Then erosive gastritis and esophagitis is very common. Whenever you have NSAIDs or use of alcohol or infections, candida, HSV, CMV or HIV can cause. And even stress. I told you, sepsis. Whenever Cushing's is there, you should remember of head injury. And whenever Curlin's is in case of the burns. This is the very important points. And Mallory waist. Please remember, whenever you define of the Mallory waist, L for L. What is there? Mallory L. L means longitudinal mucosal tear. Here one beautiful history tell you. First vomiting is normal, and second vomiting they'll have bleeding. Second or third subsequent vomiting they'll have bleeding. So always history comes. First bleeding how it is, and second and third bleeding you should ask. Second and third bleeding bright red, you should remember that Mallory waist could be there. See, longitudinal, L for L. Mallory means longitudinal. Please remember in your lifelong, Mallory waist syndrome, longitudinal mucosal tear. Dilfoy's lesion. Dilfoy's lesion, I only want you to remember only simple part. Don't complicate it. D for D, submucosa. DS, submucosa. DS, DSM. I used to remember as DSM. Dilfoy's lesion, submucosa. DSM is a subpost, so lesser curvature. Dilfoy's, submucosa, lesser curvature. This thing, if you remember, one of your entrance point is over. So please remember, whenever you deal with the Dilfoy's lesion, please remember it is a submucosa and it is involved in the lesser curvature. This is the one of the important. See how beautiful picture is there. And others, AV malformation, malignancies, and ENT bleed. Diagnosis very simple. Hematemesis. And please, this history I told you, please remember, whenever first there is vomiting, and there is first vomiting is normal, then there is a retching, followed by hematemesis is there, means it is a Mallory waist syndrome. And please remember about the alcohol abuse, NSAIDs, and AV malformations. And examination. Please, very important, very important. Please remember, whenever you see an alcoholic patient with upper GI bleed, first thing you should do is the stabilize the patient. Pulse, BP, respiratory rate, temperature, saturation, urine output. Then what you'll do, you'll put two wide bore IV cannulas, IV fluids are rushed, and then you should arrange for the blood. You should arrange for the blood. Very important. You should arrange for the blood. And then what you'll give? You will give injection Pantop 80 mg IV stat or pantoprazole 80 mg IV stat followed by 8 mg per hour infusion over 24 hours. Then injection octreotide 50 mcg stat followed by the 25 mcg per hour infusion. This is the thing you are supposed to give. And please remember one more important point I will tell you. Whenever you're dealing with the alcoholic patient, first put Riles tube with drain so that you can quantify how much blood is coming. And then lab test, what you will do first, you should send the blood group type in, cross match in CBC, RFT, coagulation profile, ECG and ABG. You should do. Each thing is important. Please remember, whenever upper GI bleed, the patient is bleeding in front of you, immediately arrange the blood. Blood should replace the blood. That is the very important thing. And you should put two wide bore IV cannulas, and you should give injection pantoprazole 80 mg stat followed by the 8 mg per hour infusion, and injection octreotide 50 mcg followed by the 25 mcg per hour infusion. These are the standing orders which you should give when you are in the casualty. Okay, so this will help you to know. And ECG, all these things we can identify for the mesenteric ischemia. Please remember, whenever a patient is on mesenteric ischemia, like this you can identify. Whenever you give food, the patient will have severe abdominal pain. He will not even allow you to touch or give the food. That thing you should remember. Okay, ABG will help you in the identify. And radiology, we don't get that much of time in emergency. This all thing, immediately you should take the patient for endoscopy. Whenever you identify upper GI bleed, endoscopy, and if there is a varicellular bleed, immediately bandage. That's it. That's it. Simple. Whenever you see a patient of varicose bleed, endoscopy, first you should stabilize the patient, give the IV fluids, to two wide bore IV cannulas, Riles tube with the drain, injection pantoprazole 80 mg stat followed by 8 mg per hour infusion, injection octreotide 50 mcg stat followed by the 25 mcg per hour, arrange the blood and immediately take for endoscopy. You see the varicose bleed, you put the varicose band in. That's it. That will stabilize. And nasogastric. Here, one important thing which was there is, that's why I went into all the studies, all the things I told you from the meta-analysis, double-blind random control trials, and cohort studies. These are the three studies you should defend. So here you see, there were few people telling that nasogastric tube may provoke, but no evidence to support the concerns that nasogastric tube passage may provoke the bleeding in patient with varices. This is the thing you should remember. Treatment. I told you, no, pre-endoscopy and post-endoscopy. Pre-endoscopy, no, if suppose patient is hemodynamically unstable, what you should do? You should do the Rock-Call score. Rock-Call score, age less than 60. Please take it from me. Whenever you see a case who is an unstable, immediately what you should do? You should do the main Rock-Call score. And I told you, see, emergent, two large bore IV cannulas, you cross match the thing, and then what you should do, you should correct. If blood is less than 7 grams or more, less than 9 grams or more, it is there, means you should give blood transfusion. Whatever it is, you should put blood transfusion. Here, one extra point which you can do is, I told pantoprazole or omeprazole 80 mg IV bolus followed by the infusion 8 mg per hour. And octreotide, how much you should give? 50 mcg bolus followed by infusion of 25 mcg per hour. And antibiotics, I prefer ceftriaxone. You give 1 gram IV stat. Okay, and then here one important point I will tell. You do INR. If INR is more than 3, what you will do? You can give FFP correction. FFP correction is loaded. If INR is more than 3 or more than 5, you can go for the protrom bag. Please remember that point. INR, if it is more than 3, please remember you should give FFP. This point you remember. If FFP with also it is not concentrated, you can give Eltrom back, you can give. Okay. And telepresent, please remember, my dear, when I was in GH, when I was in government hospital, they used to say that telepresent is very good, very good. More telepresent is very costly here, they can't afford. So telepresent and octreotide, they thought that both of them are equal, so happily you can give octreotide. Okay. And endoscopy, what I told, my suggestion, anytime you see varicose bleed, endoscopy you do immediately whenever you're suspecting the varicose bleed. So endoscopy you do immediately, and after that what you should do, esophageal bandage, that's it. Stop the source, stop the source immediately. This is the endoscopy. I think all of you would have seen. And this nowadays we are, this why I'm using, I told you, because in exam they're asking, this tube is called a Sengstrom Blackmore tube, and there is a Minnesota tube also. It is just of the historical figures, we are not using it nowadays. And then surgery, see, always this is my case, always if I see upper GI bleed, I will keep with me only. Upper GI bleed, I always say it is my case. So surgery, it is the many important. So surgery, what they can do, tips, all the things. But please remember, any case of you are seeing the upper GI bleed, please remember, always you should go for the medical therapy immediately. Medical therapy, first what you will do, first you will stabilize the patient. After stabilizing the patient, you will do the first give wide bore IV cannulas. IV bore cannulas, that is usually we use the pink cannulas, IV bore cannulas. After using the IV bore cannulas, start the IV fluids, NS you can put, and then you can give the you can use the rice tube with drain. And after that, injection pantoprazole or omeprazole 80 mg IV stat, followed by 8 mg power infusion, and then injection octreotide 50 mcg stat, followed by 25 mcg per hour, and arrange the blood. And then once you see the thing, immediately endoscopy you do. Endoscopy, if there is an upper GI bleed, esophageal varices is there, varicose banding, that's it. So always follow up the patient, always you should follow up the patient, and you should look for the advances, how is that the patient going on. So that's it, simple presentation. Actually, I'm very happy that you have given me the topic of upper GI bleed. I love upper GI bleed because I was very passionate in teaching upper GI bleed. If you do this thing, nothing, as a house surgeon, whenever you put 2 IV cannulas, give the fluids, NS, and injection pantoprazole or omeprazole 80 mg IV stat, followed by the 8 mg per hour infusion, injection octreotide 50 mcg stat, followed by the 25 mcg per hour infusion. If as a house surgeon, if you are able to do this much, I am very happy. And immediately start blood and go for endoscopy. In endoscopy, if you are seeing varicella bleeding, that's it. Varicella bleeding is that esophageal banding. This will rest the case. Okay, that's it. Parthiban, any questions?
Yes, sir, I'm here. Sir, am I audible?
Yeah, you are audible, Parthiban. So I just kept it
Yes.
very simple and easy so that everyone can
Okay.
understand this thing.
Yes,
Any
sir, yes, sir. It was
any
very beautifully
questions, sir?
presented, sir.
Thank you, thank you. Because
If
this
any
is,
questions, I request all the viewers to post it in the chat box.
because this is one of my favorite topic, upper GI bleed, because you see the patient recovers very nicely in front of you. The ease and urgency with which they recover is very rewarding. That is one of the beautiful things is there.
Yes, sir, yes, sir. Okay, I don't think there are any questions, sir.
Okay, okay. So if it is there, we will stop the section and we'll continue. That's it.
Okay.
Anything else is there?
Okay. Okay.
Oh,
Hello.
then I will close the section.
Yes, sir. Yes, sir. Yes, sir.
Okay, dear. Thank you, Amma. Thank you.
Okay, sir. Thank you so much for your time, sir. Thank you.